This video is a compilation of all the myocarditis studies I've reported on during the last year and a bit. It covers everything from myocarditis and pericarditis in children to sudden death from myocarditis in adults. This video is just a review of the COVID-19 vaccination studies and is not meant to discourage vaccinations. It's to put some context of the risks of vaccinations versus the benefits. There are chapters in the video below for each study. The first study is about children and teens in Thailand. It's interesting because it's a prospective study, meaning they were looking forward for symptoms and monitoring children going forward from their vaccination with Pfizer. The second study is about teenagers in Hong Kong, and the third is about teens and young adults in Ontario, Canada. The fourth study is from Germany, and it's about adults dying suddenly from myocarditis. It's an autopsy study investigation. Before we get into the studies, I would like to tell you a little bit about myocarditis. It's swelling of the muscle tissue in the heart. Pericarditis is swelling of the sac that goes around the heart. And sometimes people can have myocarditis and pericarditis together. There are many causes of myocarditis, such as chemotherapy, trauma, radiation, bacteria, fungal, viral infections, medications, parasites, and even toxins. As someone who manages myocarditis, insisting that myocarditis is mild is certainly not appropriate. We have some evidence to suggest that post-vaccine myocarditis on average may be a little less severe than classic myocarditis. There was a study in Lancet in adults and young adults looking at outcomes 3 months after myocarditis from COVID vaccination. There's a link to the study in the description below, and there were 836 eligible patients in that study. And the important thing to notice is that 32% were still on activity restrictions at 3 months, and remember, these were young people. 25% of this young age group were still taking medications for myocarditis, and 54% still had an abnormality on their follow-up MRI. Remember, these young people with low risk from COVID, some of whom would already have had the disease, and the vast majority of which had no underlying health conditions. There are many case reports of people dying from vaccination-induced myocarditis, including the autopsy study from Germany, which I mentioned. Here are the studies. There are timestamps and chapters below if you want to look at one in particular. Thanks for watching. There has been only a single prospective study, that means a study actually looking forward after vaccination, which was done in Thailand. Now, I read this study back in August of 2022, and I must say it's disappointing that we do not know more about myocarditis given the concerns regarding this were brought up just over a year and a half ago. It's important to let people know the risks of an intervention, especially if it's serious, even if the risks are very small or uncommon, so that people can balance the risk against the benefit and make an informed decision. The Thailand study has been peer-reviewed, and there's a link below to the study in the description. This flow chart shows what the investigators did. They enrolled 314 people into their study, and they did baseline blood work, cardiac enzymes, and echo prior to the vaccination, which was the original Pfizer vaccine in Thailand. And then they did it again day 3, day 7, and day 14 after the second Pfizer vaccine dose. And they studied participants in the 13 to 18-year-old range, and 67% were male. Now, nobody died in the study, nobody required mechanical ventilation or drugs to keep their blood pressure up. Now, the main findings on this slide are that 7 individuals developed myocarditis, which means inflammation of the heart muscle, or pericarditis, which means inflammation around the lining around the heart. The 7 males were out of a total of 202 male subjects. No females developed myocarditis or pericarditis in this prospective study. Now, the first 3 patients on the slide here were people that actually presented to the hospital and were admitted, with 1 additional patient going to the ICU. These 3 cases were symptomatic cases. Patients 4 through 7 were people who developed subclinical myocarditis with abnormalities in their cardiac enzymes, without another obvious explanation and without symptoms. So in total, 7 cases out of 202, which is 3.5%, or 3 symptomatic cases out of 202, which is 1.5%. Now, this is a lot higher than the number of symptomatic cases found in other studies that I mentioned at the beginning of the video. One might think that this is the case because the study's perspective going forward, so the young men and their parents knew exactly what the study was about. Thus, there may be people who simply do not attend the doctor or a hospital with symptoms of myocarditis, and so they're not actually counted in the incidence of myocarditis, which would obviously be much higher. This is obviously a very small study in Thailand, but it's disappointing that the vaccine manufacturers or other researchers have not evaluated this problem further to get a better sense of the scope of the disorder. The vaccine manufacturers are making billions on their vaccine, and the onus to me is clear on them that they need to prove safety when safety concerns are raised. The onus, of course, is also on governments to require the companies to do this in a timely fashion, which has not occurred in this case. It would not cost Pfizer or Moderna a lot of money to do a much larger study like the Thailand study, given that they're making billions of dollars annually. This study was published in the Journal of Clinical Infectious Diseases. It's from Hong Kong in China, and it looks at the epidemiology of myocarditis and pericarditis in adolescents following the Pfizer vaccine. That's the vaccine that they had in Hong Kong. Now, in Hong Kong, they wanted to look at myocarditis and pericarditis in Asians. This is the first time they've studied it in this particular ethnicity group. Between June 2021 and September 2021, there were 33 adolescents in their study who developed either myocarditis or pericarditis or a mixture following their Pfizer vaccinations. Now, 88% were male and 12% female, very similar to previous studies. The median age was 15, and it was more common after the second dose, occurring in 82% of people in their study, and this is what we've seen in other countries. This is the reason why some countries have gone with 1 vaccination in this age group, and some countries that are using 2 are giving them 8 weeks apart. I've talked at length in previous videos of the importance of giving your first 2 vaccinations 8 weeks apart. It's well documented in medical research now that you get a much better immune response, and it's possible that the incidence of myocarditis and pericarditis could be less if they're given further apart. Even though after my own first vaccination, they wanted me to come back in 3 weeks for a second, I waited for 3 months knowing that I would get a better immune response with more time in between the 2 doses. Now we have data with different time frames, and certainly once you get beyond 8 weeks, it's as good as 3 months and 4 months. This is based on Canadian and UK data. Back to the Hong Kong study, all of the cases fortunately were mild and required conservative treatment. The incidence overall for all adolescents were 1 in 30,000 after the first vaccination and 1 in 4,700 after the second vaccination. If you just look at the males alone, their incidence was 1 in 17,000 after vaccine number 1 and 1 in 2,680 after the second vaccination. Now, the 1 in 2,680 is the highest risk that I've seen with the Pfizer vaccine. In all the studies where Moderna has been in part of the study, typically the rates for Moderna is higher because of the higher dose. Now, myocarditis is still very uncommon, but I think it's a risk that people deserve to know prior to vaccination. I want to report on a study that was done in the province of Ontario in Canada. This province includes the cities of Toronto and Canada's capital city, Ottawa. This looked at the incidence of myocarditis, which is inflammation of the heart muscle, as well as pericarditis. Pericarditis is inflammation of the sac that surrounds the heart. Now, there's a long list of causes for myocarditis. The main causes include viruses, fungi, bacteria, parasites, as well as toxins, medications, radiation, chemotherapy, trauma, and autoimmune diseases. The list for possibilities of causes for pericarditis is actually very, very similar. The study in question looked at the frequency of these 2 conditions between December 13, 2020 to August 7, 2021. This was done because there were significant signals from the United States as well as Israel about myocarditis and pericarditis secondary to the vaccine. Since the start of the immunization program, they found 204 cases in Ontario of either myocarditis or pericarditis, which met the Brighton collaboration case definition for those two diagnoses. So we know that there are definite cases. Now, of these 204 cases, 79.9% occurred in males and 69.6% occurred following the second dose. The average time from vaccine administration to symptom onset was 2 days, and 79% of cases occurred within 7 days of vaccine administration. There were 72 cases of myocarditis, 58 cases of pericarditis, and 74 cases of a mixture which we call myopericarditis. 99% of the cases attended the emergency department, with 72% of the cases getting admitted to the hospital, and 1.5% of the cases ended up in the intensive care unit. Now, fortunately, there were no deaths. I was very disappointed to not see any data on the patients that were admitted in terms of their length of stay, whether there was cardiac dysfunction, the levels of their cardiac injury blood test markers, and whether there were things like heart failure or rhythm abnormalities. As you can see on this graph, the majority of the cases occurred after the end of May, when vaccination programs started to involve younger adults. Many second doses were also around that time being administered. There was also an increased vaccine supply, particularly of Moderna, as well as release of an enhanced surveillance directive to follow myocarditis and pericarditis. So at this point, doctors, as well as people who were vaccinated, were more in tune to look for symptoms that might indicate myocarditis or pericarditis. These symptoms of this would be chest discomfort, palpitations, shortness of breath, which typically would occur, as I've mentioned, 1 to 7 days post-vaccination. This is the rate of myocarditis and pericarditis per million doses administered by age by Pfizer in green and Moderna in blue. You can see that the majority of cases are occurring in people under the age of 40, with a much higher incidence in the younger age group. As Pfizer in Ontario has been given to people below the age of 18, there's an increased rate in the green line of Pfizer at those ages. Moderna has not been approved in Ontario, and so its statistics only go down to the age of 18. When you look at the Moderna statistics, which is the blue line, the risk of myocarditis or pericarditis is much higher in the 18 to 24 age group. On this slide, the overall reporting rate in all age groups of myocarditis or pericarditis following the Pfizer vaccine was 8.7 per million following the second dose compared to 6.4 per million following the first dose. For the Moderna vaccine, it was higher. It was 28.2 per million following the second dose and 6.6 per million following the first dose. What they found, though, was that the frequency was highest for individuals between 18 and 24, and it was much higher following the second dose. So here, Moderna was 263.2 versus 37.4 per million doses for the Pfizer vaccine in this age group. Now, this difference in the reporting rates persisted when the analysis was just restricted to the June 1st to August 7th period, which was the surveillance directive time. To put it in better perspective, Moderna at 263 per million is a risk of 1 in 3,800. For the Pfizer second dose, their risk was 1 in 26,000. These numbers are in line with what has been seen in previous observational reports from the USA as well as Israel. These are a definite increase from the baseline incidence of cases that we would expect to see in the general unvaccinated population, meaning the vaccine is definitely causal here, meaning it's causing what we're seeing. It's possible but not proven that the higher frequency with Moderna over Pfizer may be simply due to the dose of the Moderna vaccine. The Moderna dose is 100 micrograms in each vaccination, whereas the Pfizer mRNA vaccine is only 30 micrograms. So there's a threefold difference there. I would also point out that the dose given to people in the 12 to 17 age group are exactly the same as the adult dose, which may not be optimal. Many 12-year-olds are not fully grown. I would point out that there have been numerous case reports in children between 12 and 18 in a number of medical journals, and myocarditis reports early in the pandemic from COVID-19 infections, they mostly stemmed from an abnormal MRI scan without symptoms, without ECG abnormalities, and without significant troponin elevations. Troponin is a marker for cardiac injury. There were a handful of flawed medical studies which nearly stopped the US college sports scene last year due to this. Now, the pediatric cases that I'm talking about post-vaccination are in contrast to myocarditis from the virus because they had significant troponin elevations, which is a marker of injury. They had abnormal MRI scans, abnormal ECGs, and significantly elevated inflammatory markers. Heart ultrasounds also demonstrated reduced cardiac function in some people with this diagnosis. So when it comes to the vaccine, these cases of myocarditis are definite cases with not just a mild abnormality on an MRI, but many other abnormalities seen on their tests. Over the years, I've managed numerous people with myocarditis and pericarditis in my practice. And I point out that we would recommend avoiding high-intensity exercise for 6 months after the diagnosis has been made. So it isn't always a benign diagnosis. It appears rare in the literature thus far that vaccine-induced myocarditis causes any long-term cardiac dysfunction, but there's always a small chance of that from the vaccine. Myocarditis itself can be a serious condition, but it's been downplayed in the media. So there are some things to consider moving forward. Should we give a lower dose vaccine in this age group or simply a single dose? These are important considerations. People can feel risk differently. Some patients fear the illness more than the risk of the prevention or treatment. Understanding concerns of the patient is important to try to put the risks and the benefits in context for them. Parents or the individual may feel more risk from the virus than from the vaccine, or even vice versa, despite whatever data you provide. There are many factors that come into play, such as whether the young adult has comorbidities or whether their parents or grandparents that might live with them are at risk also. And if so, in this situation, it would make sense to consider vaccination. This kind of discussion with your physician is important. And of course, it should be up to the kids and parents to decide. This is a nuanced decision. This is why in the UK they've not been vaccinating people under the 18 as of September 2021. They're looking for more evidence-based data. The data, of course, can change with new variants, and we do need to be ready to change our course if the data changes. Today I'm going to talk about an autopsy-based study from Germany. It looked at people who died suddenly and unexpectedly within 20 days after receiving a COVID-19 vaccination. This has just been published in Clinical Research in Cardiology, and as always, there's a link below to the study in the description. Now, what did these people die of? We know that the incidence of this seems to be on the order of about 1 in 5,000 in young males after the second vaccination with Moderna, but it's less common with other vaccines, and it's also less common in females and other male age groups. Many countries have not used Moderna vaccine in people under the age of 30, and a number of countries have delayed the second shot further away from the first to reduce the chance of myocarditis. Now, some have said that the risk of myocarditis for COVID-19 is actually greater than the risk of myocarditis from vaccination. But this is not true if you look at a large study from the UK or a large Nordic study, which I've reported on. Now on to the German autopsy study. At the University of Heidelberg, they found 35 cases of people with sudden death at home occurring within 20 days following SARS-CoV-2 vaccination. Now in 10 of those cases, the autopsies revealed other causes of death. They looked at the remaining 25 bodies that were found unexpectedly dead at home, and they found 5 cases of likely or possible vaccine-related myocarditis with no other reason for their death. All of these people died within the first week of vaccination, with the average length of time 2.5 days post-vaccination. Now, of course, there were no blood tests, ECGs, imaging, or clinical findings because none of these people sought medical attention before they suddenly died. In one patient, a witness described a rattling breath shortly before discovering an absent pulse. In another person, they complained about nausea and were found dead soon thereafter. Resuscitation in that case was not successful. The other 3 people were simply found dead at home without any information about terminal symptoms. According to the available information, none of the deceased had previous COVID infection, and swabs taken for the COVID virus were negative at autopsy in these people. 4 people died after the first vaccination, and the remaining case was after the second one. There were 3 females and 5 males in this autopsy study. The average age was 58, with a range of 46 to 75 years of age, which is certainly older than what I've been talking about in the above studies. As on this slide, you can see the 5 cases, and in these 5 people, it's important to note that they found no other cause of death. The cardiac pathologist felt that 4 out of the 5 cases were definitive for myocarditis according to our standard Dallas myocarditis criteria. They felt that 3 out of the 5 were likely related to the vaccine, with 2 out of 5 being possibly related. The pathologists described their findings in the study, and in all 5 cases, the microscopic findings were the same. They did say that during the last 20 years of their autopsy service at the University Hospital in Heidelberg, that they did not observe comparable microscopic cardiac muscle inflammation or infiltration like these. This autopsy information in 5 patients allows physicians and, of course, pathologists to better understand situations where we may have a patient in the hospital that we choose to biopsy. This way, findings can be interpreted and correlated with what they found in this study. They summarize by saying that in these 5 patients, no other cause of death except myocarditis was identified, and hence myocarditis has to be considered the likely mechanism of death. They felt that the myocardial damage they were seeing in the cases were not sufficient to suggest that poor heart function was the terminal cause of death. And so most likely an abnormal heart rhythm, either a cardiac arrest with no electrical impulse or another life-threatening rhythm, had to be assumed as the mechanism, the immediate mechanism leading to the patient's death ultimately. Now, myocarditis-related acute cardiac arrest due to life-threatening rhythm disorders is well-established mechanism in other cases or causes of acute myocarditis. Their summary is a very small number of patients, just 5, and it's obviously descriptive or observational. It gives no idea about the frequency of myocarditis from vaccination, and obviously, ultimately, it does not provide a direct causal link from vaccination to myocarditis, and I can't emphasize that enough. They finish by stating that considering that this adverse event, which is fatal, may affect healthy individuals such as registry and surveillance programs, they may improve early diagnosis, close monitoring, and treatment. If these deaths at home were secondary to vaccination, we of course may be missing some severe myocarditis cases in our studies. Not every death at home will have an autopsy. Now please note that this video is clearly not anti-vaccination. It's reviewing research into myocarditis, and vaccination has been helpful for people, particularly at high risk of a severe outcome, to prevent hospitalization and death. But with any intervention, it's important that we as physicians select the right people for the intervention, balancing the risks and benefits. And the risks, of course, need to be known. Certainly risks that are serious, even if very uncommon, need to be elucidated and understood. This allows physicians to have good risk-benefit discussion with patients so that patients can make an informed decision. As we go down the road and people receive more vaccines, more boosters, whether it be annually or what is recommended for people at high risk, we need to understand the benefit in that group as well as the risk. We also need to know what it is for different patient populations, because obviously the risk is going to be different if somebody's young and healthy versus older, as well as whether these people in question that you're talking to, whether they've recently had infection or how many infections that they have that might deliver some immunity to them each time they get reinfected. These are the sorts of things that we try to balance when we're making decisions on health care for people.